Okay, so we are looking at Chapter 21 in the NSCA Essentials of Personal Training, and this chapter speaks specifically regarding orthopedic injury and rehabilitation concerns. I wanted to shoot this video and actually talk more about this in class, in person, because you're going to come across a ton of people who have different orthopedic concerns, who have previous injuries, and perhaps have just made their way through rehab. Now, I will say this. So often you'll come across a person and begin to work with them, and the statement holds true across the board. So often chronic discomfort and chronic issues with your person were created by, or the root cause is, a acute injury that was never fully addressed or rehabbed properly. And so when you work with these individuals, this chronic condition that has manifested itself over the course of perhaps years was a result of a car accident, a trip and fall, a broken arm, or any number of different injuries. And the person didn't fully go through their rehab course, didn't fully take care of themselves, didn't fully strengthen afterwards. And as you begin to work with a person, you start to notice maybe an imbalance, and you question them on it and say, well, you know, when I was in that car accident and had whiplash, I've always had this kind of pain in my shoulder. Well, you know, the root cause is not the end result. The root cause is something else. So I can't stress this enough. When you work with your people, you're going to have people who present with chronic conditions that are a result of an acute injury that was never fully resolved. Let's jump in. So which of these terms is used to exclusively refer to inflammation of a tendon? So anytime you talk inflammation in medical terminology, you need to associate that with itis. I-T-I-S. Inflammation can manifest itself in any number of different places. It could be bursitis, tendonitis, colonitis. It could be anything, right? So itis of the tendon can be found on 565, and it's tendonitis. That'd be B. All right, so which of the following terms describe the composition of scar tissue? And when you work with individuals, you may have some people who went through a surgery, and as a result, they have like keloiding, that kind of scar tissue that you see, and that has a different composition than muscle tissue and skin, and it's not as plastic or elasticy. Think of any kind of cut you've ever had in your life when you have scar tissue. It feels kind of stiff. When you work with individuals, you find that perhaps you'll have individuals who have limited mobility or have variations in movement patterns as a result of keloiding, scar tissue, etc. And that's a direct result of the collagen that's seen when you have scar tissue in place. Think no further than clients who perhaps delivered their babies via C-section. Their abdomen will respond differently than others who did not deliver via C-section. You'll find that to be the case in even shoulder replacements, shoulder surgeries. The scar tissue will have an effect on movement. So we know that for number 2, it's collagen crosslinks. All right, which of the following is incorrect? Now this, you have to kind of decipher this a little bit. There are different phases, and I can tell you, when you look at this, they do overlap, and it's not as though they have a finite amount of time going through the inflammation, the repair, and the remodeling phases, because you might do something with your client and you'll go through and try to do some manual work with them, but you start to inflame them yet again. So you have this process where it's kind of a give and take, where you have to push your people along, but you might cause some inflammation in the process, and that's part of the curve, and you make that very apparent to them on the front end. We're going to do some work, we're going to push you a little bit, you might have some pushback from your body, and that's where the inflammation comes in, and when that happens, we'll adjust accordingly, but it is not finite. So when you look at this, the incorrect answer is does not overlap, because you're going to have variations of this as you go through the healing process. So I somewhat disagree with this one in the book, in which of the phases of healing are functional strength and exercises advised. You have people who go through a cardiac surgery or a knee replacement or a hip replacement, and they are in post-op recovery. They wake up, and within 24 hours, easily, they have them up and walking down the hallway. that can't be any more functional, right? You think of your day-to-day activities, and walking is a big ADL, that's highly functional. So I look at this and go, the functional component, when you look at it, encompasses a couple different things. Sure, it's about strength training. All right. But for me to move through a range of motion and have a functional range of motion, whether it's throwing a ball, walking, whatever it may be, there also has to be a functional side that is inclusive of mobility as well as strengthening. So I look at it and say, with mobility, to get through a range of motion, unless I'm totally helping that person through that range of motion, there is a functional strengthening component, even when they're working on the mobility aspect of the rehab. So I would state that functional strengthening starts day one, minute one, when you work with people, but it takes on different variants as you work with them. So it's not going to be cut and dry. So with this, you kind of have to decide for a little bit, but they're saying in which phases of healing are functional strength training advised. They state the remodeling phase only, so more towards the end of the process. And I, again, would state that as you go through the process with the client, you'll have functional mobility that will also have a strengthening component to it. They're just inherently related. And so to that end, while the book wants you to go with remodeling phase, I will tell you, as somebody who's worked with a number of people who've been through physical therapy, who've been through knee replacements, hip replacements, and also have had different types of surgery, that you start that phase earlier. It's not at the end of it, it's at the beginning. All right, excessive forward flexion. Okay, we know what that looks like. And oftentimes this is presented in terms of the hip flexors are tight, the hamstrings are tight, and that's pulling on the pelvis and causing a low back pain. And inherently, this is many times true. You have people who have low back pain, and they also have very tight hamstrings and tight hip flexors because they never stretch. They sit all day in the same dang position, bent knees and in hip flexion in a chair while they work. And so, of course, they're going to have shortened musculature as a result of that. So you look at this and you go, okay, and you can find arguments on both sides of this, by the way, where it's just people say it's nonsense, that hamstrings have nothing to do with low back pain, it's not the hip flexors. And I can tell you that when people come in with back pain, I go immediately to my toolbox of flexibility work for the hamstrings and the hip flexors and the quads, and work on mobility, mobility, mobility. And it's an intervention that's always worked for me for my clients. But the book presents on 569 one scenario that is a little bit more specific to stenosis in terms of you shouldn't do certain movement patterns, right, that will aggravate the low back itself. And I found this to be a little bit confusing, but if you read a little bit further and you go into 570 makes it pretty clear that the hamstrings, even though they're considered lower body, blah, 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 will help in terms of how they tug and pull on the pelvis because of how they affect the pelvis when they contract. And I would take this a step further and say, you're also looking at quadricep to a certain degree, and also looking at glute to a certain degree, and other muscles that are inherent to the pelvis and pelvic floor that help articulate and also stabilize the pelvis. So it's not just hamstrings, as the book wants you to believe. There's a bit of a more complex component to it, a greater complexity. And it's not one-dimensional, but for this answer in particular, they're looking at hamstring stretching. I will tell you it's hamstrings, hip flexors, quads, glute, and muscles inherent to the pelvis itself. All right, so number 6, which of the following exercises is not precautions or contraindications for individuals with herniated disc injury? And they kind of infer this because in the text they go through and they state, well, may include full sit-ups, that takes B off the table. It also may include a squat, okay, rowing movements, and the deadlift, well, trunk flexion and lumbar flexion is going to take standing toe touch off the table. So it ends up being C, plank, because if you just think of it in terms of your anatomical position in a plank, or your positioning in a plank in terms of how your spine is aligned, you don't have trunk flexion at all. There is no lumbar flexion in there. The issue you have though is in a plank, if somebody is not strong enough in the midsection to have good strength and integrity in their midsection, in the core area, when you put them in a planked position, that will immediately elicit a protective response in the muscles in the back, and many times they go right into spasm. So I would urge you to use caution on doing a plank with somebody if they do have a herniated disc injury or they're exhibiting any kind of symptoms of that, because you can flame them up right away. Which of the following is an exercise contraindication for shoulder instability? On 576, this one's pretty straightforward. We're looking for behind the neck lat pull down and also shoulder press. You know, when you get into those exercises and you have the arms above your head and you're doing behind the neck, it forces you into greater external rotation, and a greater external rotation causes, if you think of all the musculature in the shoulders and how they all attach to the humerus, when you externally rotate, you're actually pulling the fibers closer together on that. And I'll show you a quick video here in a second, or I'll embed that into our lecture so you can see what I'm talking about. Which of the following swimming strokes is considered safe? Now this works on the presumption you even know what a swimming stroke looks like. So on this one, they talk about the instability component for the shoulder. And okay, so this specifically, okay, the freestyle, the backstroke, and the butterfly, the most aerobic training is performed with the exception of these dance steps. Okay, swimming, and especially these. So freestyle takes D off, backstroke takes C off, and butterfly takes B off. That leaves you with the breaststroke. I'll leave you to look that up. Which of the following exercises is contraindicated for a client following ACL reconstruction? And again, here we are on 583. They would say end of range leg extension. I will tell you that if you're doing end of range leg extension on a leg extension piece of equipment, your risk of hyperextending is quite low. If you do terminal knee extension in a standing position with a band wrapped around the back of the leg, your risk of hyperextending that knee is quite low. And those will be two rehab protocols that you'll see done many times. But a end range movement pattern for leg extension is what they're looking for. But I will tell you, you'll see that as part of a rehab protocol many times for your people. Which of the following exercises is contraindicated for the client following hip arthroscopy? All right. With this, I've dealt with hip replacement, hip arthroscopy. And when you look at this, they're looking for ballistic or forced stretching. But of what? Of the hip? Or we're looking for shoulders or what? But eventually, I will say this, when you work with your people, you can get them back to a place where they're doing this type of mobility. I had a young lady who had to have her hip cleaned out. She was a dancer, danced in high school, she was in college, and had, I believe, the starts of arthritis. They went in and cleaned out the hip. So we worked first on static strengthening and working on the pelvis. And then we worked on some mobility, then we worked on some strength, and because her sport requires a lot of ballistic movements, we had to have ballistic stretching into the equation. So it kind of was dictated by the person. So to that, guys, I'm going to bail out and go ahead and load this up. Thank you so much.